Hello, my name is Jake Sweeney. I'm one of the program coordinators here at AC, and today I'm doing an overview of our pharmacology manual, and I'm going over Midazolam, or Versed. This is a benzodiazepine class drug. They're also referred to as sedative hypnotics or anxiolytics. Its mechanism of action is that it's a short-acting benzodiazepine that has sedative hypnotic qualities as well as amnestic properties. Benzodiazepines facilitate the activity of gamma-aminobutyric acid, also known as GABA, at receptor sites, and what this does is help reduce neuronal excitability. The indications and the way this works is that they can be used for things like sedation or continued sedation of intubated patients, control of seizure disorder, combative patients, conscious procedural sedation, or as an induction agent for RSI. Contraindications of this drug, like with anything, are hypersensitivity or allergies, respiratory depression, which is, once again, it's a relative contraindication simply because patients are in a respiratorily distressed state while they're actively seizing. So the only time we'd really be concerned about this is if potentially somebody was having a significant amount of alcohol on board, for instance, and we were trying to sedate them. I might not select a benzodiazepine simply because of that possible negative interaction. I'd consider another sedating agent. And then once again, amnesia, which is a relative adverse effect simply because that's really more a intended or side effect, especially when we're using it for the purposes of procedural sedation. Precautions to take, as with all benzodiazepines, are that they have a significant potential to be worsened or their side effects are increased if the patient has any other CNS suppressants on board. Things like alcohol, opiate narcotics. For instance, if you administer another medicine that's a CNS depressant for the purposes of nausea control like promethazine, if you were to use this drug, they would potentiate each other and it could introduce like a significant amount of respiratory depression. Our dosing schema for this, like with many types of benzodiazepines, ranges from that for behavioral or procedural sedation. It ranges from that 2 to 10 milligram range. You generally increase that range if you're administering it through a slower acting route like nasal or intramuscular, and you can titrate that more closely if you're administering it through an intravenous or intraosseous route. For the purposes of controlling of seizure disorder, the dosing is the same, but generally your max dose ends up being about 10. Some local protocols break that down to a max single dose of 5. Some just go straight to a max of 10. Our pediatric dosing range is generally in that 0.1 to 0.2 milligrams per kilogram range. If you're administering it through a route like IV or IO, I'd start with that 0.1 milligrams per kilogram up to our adult max. And if I'd been administering this drug through a slower acting route like nasal or intramuscular, I would consider giving the higher dosing range. Pearls is just remember, Midazolam is one of the strongest benzodiazepines on the market. It is significantly stronger than diazepam, generally considered about 3 to 4 times more powerful. It has very potent amnesic properties, which can be helpful, especially if we are using this for conscious sedation for painful procedures, things like resetting of bones or transcutaneous pacing, cardioversion. But because those amnesic properties are very powerful, a lot of times it's a good loading dose drug to give prior to something like cardioversion. It's just also important to always understand that benzodiazepines can control seizure activity, and if you do administer a large dose, you need to be very aggressive with your airway on oxygenation support on the off chance that the patient is respiratorily depressed following cessation of seizure activity. The only other thing to keep in mind with any of our benzodiazepines is really that your GABA receptors, and this is debated, but they can be oversaturated by a set amount of benzodiazepine. And if that does occur, you may need to move to some other form of breakthrough seizure control or anti-epileptic medicine like a Keppra infusion. And that if it doesn't work the first time, you're going to need to find some way to escalate or at least be aware that you may have to heavily work to oxygenate or ventilate this patient even through seizure disorder.